early stage, stage 1, 2, 3, are more likely to be cured than stage 4. However, you know, the word the cure is, you know, we use it in cancer, but there's not a lot of time. I think it's a strong word, reflect what there is, because people don't complain much about diabetes, although we don't have a cure for diabetes, right? We really don't. People don't complain much about alopecia. We don't have cure for that. So there's a lot of condition, whether dangerous or not, that we don't have a cure. So I think we look together, this is what I showed in my talk, as is the cancer regressing? Is the patient still on therapy? How's the side effects profile? What's the quality of life? Is, you know, 1 pill a day? But to answer your question is, if you're really talking about cure, meaning just we did one treatment, whether it's systemic treatment or whether it's surgery, and we don't have to deal with it or even go to a doctor. It applies for all cancers. If the cancer is small, is earlier stage, the chances of it being cured, if you want to use that word, is much higher than it would become more what we call advanced or locally advanced.
Other questions? Of course.
Have you ever, is it possible to take tissue or blood of a person and apply certain medication to see, to use it as indication whether that's going to work for a person?
In fact, that's a good question. This has been done in the 60s and 70s, what we call the clonal assays. And that was done to test for sensitivity to chemotherapy. And this has very largely failed, mostly in breast cancer, sarcoma, and others. However, currently there are new methods that are in development and not approved yet that uses proteomics and others, and they seem to be promising. Definitely not promising in a way that you know, cancer is completely gone, but they seem that this is more so the way. They're not ready for use, even in the form that is probably the most pure form, where you can find a mutation. That's probably the best luck, if I have to say, because drugs, a druggable mutation, and I used that word before, a mutation where there's a drug that works on it. Even if the drug works, it works, you know, not for a long period of time. Is this the problem in our drug, or because the cancer develops a resistance, or what? That's the next area of research. But I can tell you at this time, you know, seeing a patient, taking a blood work, and taking, you know, part of the tumor, putting it in a machine, and coming out with a result, you know, that, oh, you should definitely use that drug and others. It's not taken into routine practice, although there are labs around the country that do that, and there are even some insurances that are getting those tests, you know, approved. But it's not being taken because the results we've seen are, at best, in some patient incremental, and someone used that word. There haven't been, you know, major results, and part of it is because it's the complexity. The complexity, you know, remember, a tumor is in the body around many, many cells we call stroma, the collagen, everything, with different blood, with different, to take it out and test it outside where the host is, may give you different, you know, results than when it's in the body itself. So it's still not simple, but I think this is an important way to go for the future. So we're seeing a lot of clinical trials, we believe this is the right way, where they require a biopsy, a fresh tissue of a site, of a metastatic site. Yeah?
It has to be fresh.
It has to be fresh, so we're requiring, but this is 2 years ago, or a year ago, this was unheard of. But if we don't start doing it, and of course it's much harder for a patient, for a doctor to coordinate studies like this. Because all what we have in terms of tissue, the tissue, for example, from the original, what we call nephrectomy site. Well, what happens 2 years when the kidney was taken and preserved in formalin or in, you know, or another material in paraffin, is not maybe the same, the protein acting like the one you know, when you can access the tissue directly. But then accessing the tissue directly like this, when it's not clinically indicated, when we don't have a test that is 100% going to benefit, is a problem itself. It's somewhat an ethical problem, unless you have a good rationale. And when we try to write that kind of trial, and I've written a couple, Dan Shaw, who's a colleague of David McDermott at BI, has written a lot. There's a lot of pushback from the IRB and everything. How's the method? Why are you submitting a patient to biopsy? Is it reasonable enough to do it? Well, to us, it seems that that's the next best way to do things.
And if you do blood instead of tissue, that doesn't sound invasive. But would
Correct,
blood not be a good indicator?
Yeah, do we have the amount of cancer cells enough in the blood? Are these the cancer cells? Are things diluted? Maybe the cancer is not spilling much in the blood. Maybe it spills a bit, then it goes to the organ and doesn't spill. That alone also presents a lot of challenges. So it is going there. It's not completely ready for prime use. David, do you want to add anything?
Sure. I mean, I think what you're asking for, as Tony said, is not the reality for most kidney cancer patients. It is being used in other tumors, but part of it is we're getting a better sense of what treatments might work for kidney cancer, and but with doing the testing you're describing, we may get new clues, of which genes are important, which proteins are important that drive these cancers. But in the end, for people living with active cancer, you need better treatments. You need different treatments that can block the action of these important proteins, these new things we might discover. And we lack, to a certain extent, we might have an idea of what we'd like to block, what we'd like to stop, but we don't necessarily have the tools to do it. So for example, you hear a lot about genes as driving cancer. We're not able to turn on and off certain genes. It would be nice to do that, but we can't do that yet. I say we meaning, the field of oncology. But if in cancer, if we could do that, are there certain genes in kidney cancer that we would target? Absolutely. So part of this is a limited understanding, but part of it also is a limited ability to do the things you're asking for. But I think one thing is for sure is that as people get treated in the future for all types of cancer, we're going to be looking at a lot of their genes and seeing which ones are important, and hopefully coming up with better treatments and doing blood tests like you're talking about, looking at blood cells that might have cancer in them, and seeing if we can turn that into better treatments. But right now, that's sort of, it's not quite science fiction, but it's a little bit further away than people living with cancer, want to hear. We need to move faster. Yes, Regina.
This is going to sound a little bit far out, but I've heard that there are places in Germany and other places where they superheat the blood to, you're giving me a blank look. They superheat the blood and then fuse it back into the patient, transfuse it back into the patient. Do you have any?
Well, I know. In fact, I don't know about that, if they eat it. I don't know, David, if you heard. I can tell you something, in a passionate way. If there's a treatment anywhere in the world that works, you bet we're going to go in this country and take it and bring it here. Period. No further. You bet. So that's something that you bet, and even if we don't understand how it works, you bet it's going to come here. Whether it's the right way to do it or the wrong way, it's going to come here. I can tell you things about, because I've seen patients going to Germany. There's a vaccine. We talked about the adjuvant study. You remember when Choueiri? There's a trial that is published in a very respectful journal called The Lancet. 10 years ago, David, 15 years ago, that uses a vaccine from patient, and it shows, the trial, that it decreases the risk of recurrence by around 30–40%. When they applied for approval in the United States, and I'm not sure even it's approved in Germany, the trial is published, and when we train in the field of kidney cancer, when we go to Journal Club, know what Journal Club is, we take an article and we just kill it. We say, this is wrong, this is what they did.